The title of my lecture today is PMP Appendiceal Cancer, Little Organ, Big Problem. And so I'm just going to go over some of the nuts and bolts of this issue. When I meet people that are coming to my clinic that have just gotten this diagnosis, I use a few type of the acronyms for it, and this is one that I feel like people are in. This disease truly is the perfect storm. I don't know if you recognize this. One of my cousin's husband is a fisherman off of New Bedford, and every time I see this picture, I think of him out there in one of these little boats. But this is a perfect storm for a number of reasons. It is a rare tumor or cancer, and I specifically say tumor or cancer, and I'll get back to that in a little bit, that is complicated by the unique anatomy of the appendix, and we're going to go over that a little bit, the unique biology of what these tumor and cancer cells do, and we heard a little bit about that they make this gelatinous, mucinous stuff that gets out of the appendix and into the belly cavity. And unfortunately, at this point in time, one of the best available treatments is one of the most daunting therapies that we offer in medicine, and that's what Dr. Whalen was alluding to. We need better solutions for this problem. Just to remind everybody a little bit of the anatomy of the appendix. The appendix is really just a flimsy little organ that hangs off what is actually the beginning of the large intestine, and it actually starts in the right lower quadrant of a person's belly. And you can see it there in the middle figure. It's that little finger-like projection that hangs off what is called the cecum, or the right side of the colon. And normally it is about the size of a little finger, and the picture on the lower right is a picture from a laparoscopy. So this was taken at the time of a surgery, and the little squiggly white line that goes across at the bottom is actually the appendix. That's a normal appendix. So the normal appendix is, again, about the size of your little finger. It's very thin, and it really just doesn't do much except get people into trouble. It causes appendicitis and it makes tumors, and that's all it does. Just a little bit more anatomy, because I think this will help people understand some of the next slides that are coming in Dr. Alexander's lecture. The peritoneal cavity, we talk about this, peritoneal surface malignancies, the peritoneal cavity, the peritoneum. The peritoneal cavity is really just the belly cavity in which all of our organs exist. Our stomach, the liver, the spleen, the small bowel, the large bowel. It's a space. It's the space inside your belly cavity. When you feel your intestines gurgling and moving, they're in that peritoneal space. And the peritoneum is a lining, a thin lining of that space, like a balloon itself. It is almost see-through, but it actually has some integrity. And so what's been remarkable over the past few decades is people like Dr. Alexander and Dr. Sugarbaker have recognized that this peritoneum, this lining, is a barrier to letting any of those tumor cells get out of the belly cavity, and it is also allows us as surgeons to be able to operate and remove these tumor implants that have gotten outside of the appendix and are growing on this peritoneal lining. Mucinous tumors and cancers of the appendix are supposedly very rare. I put up 1,000 to 1,500 new cases per year. Dr. Alexander and I have been talking during his visit here that we really think that the incidence is much greater than that. I mean, how can we possibly have as many people that I know that have this problem here in the audience if it's truly this rare? We question, has it just been misdiagnosed all along? Are people being told they have a tumor of the colon rather than the appendix? Are ladies being told they have ovarian tumors instead of appendix cancers? Or is the incidence really increasing? Is there something in our environment that's changing? The bacteria, the flora in our intestines based on the food that we're eating, the antibiotics that we're getting, all very interesting questions. And as Dr. McAvoy mentioned already in his lecture, these tumors arise from a type of cell that we call a goblet cell. And these goblet cells line the inside lining of the appendix. So if you remember, the appendix is like a balloon, and it has an outside and an inside lining. And that inside lining is lined by these cells that we call goblet cells. And these goblet cells, their sole function in life is to produce this stuff that we call mucin. And as Dr. McAvoy mentioned, it is a jelly-like substance that is normally just excreted by these cells inside the appendix, and then it goes from there into the colon. it mixes with stool and just comes out, and it's part of our natural digestive system. So what happens, here's where we get into the perfect storm. What happens when a mucin-producing tumor or cancer occurs in a thin-walled, balloon-like structure like the appendix that you saw up there? Now, for anybody who's a little bit squeamish, there are a couple of slides from surgery coming up, so I just want to put that up as a warning. So sometimes what we'll see is a person will come in complaining of some right lower abdominal pain, and when the general surgeons get called, the first thing they think of is appendicitis. And this is a CT scan from a person who came in with right lower quadrant pain. And when you're looking at a CT scan, as I explain in clinic, if anybody who's been with me, we're looking at the person as if their feet are projecting out towards the audience and their head is back behind the screen, and as if they're actually laying in the CAT scan right now. So on that side over there is the patient's right side. Towards me is the patient's left side. Anything that's very dense like bone is white, so you see the pelvic bones there and the spine. Anything that's very light like air is black. You see some black specks, that's air in the colon. And then I've circled an area in the right lower quadrant that has some, looks like a structure that's filled with a grayish fluid. And that is the appendix. Clearly not the size of the person's little finger. And if you take this person to the operating room, this is what you might find. So what you're looking down at, the metal thing, is actually a retractor holding back the abdominal wall. And that tubular structure in the middle with a big hole in it is actually the appendix. And it's very thickened, and you can see what has happened. So you've blocked the opening of the appendix. It fills up like a balloon, and just like a balloon, the wall gets very thin, and it can rupture. And then after that, this is actually the appendix taken out at the time of surgery, and you can see that hole in the appendix caused by the tumor and the distension. And what can also happen is you can now, at risk for developing what we've talked to you about as a pseudomyxoma peritonei, or the PMP. And that is basically a description of mucinous ascites, mucinous fluid in the abdominal cavity. And what you're seeing here below the retractor, the metal thing on the upper part of the figure, and if you look, it looks like a little bit of yellowish, orangey kind of jello there at the bottom of the opening, and that is the pseudomyxoma. And sometimes it can get very extensive, and you can actually remove liters of this at the time of surgery. And unfortunately, if it goes for long enough and it's contained within a person's belly cavity, just because, again, as many people have heard these stories, people just it's the silent disease, like Sharon Hilke was saying. It doesn't cause a lot of symptoms to let you know that it's there until it gets very advanced. And over time, as it builds up and pressure kind of compacts this mucinous stuff, we can see pseudomyxoma that actually looks like this, where it's the gelatin or gelatinous mucinous stuff has solidified. Who gets this disease? Well, men and women actually get it equally. It's long been thought that women got it more often than men, but if you really look through the data, it actually appears that it's pretty equal across the board, men and women. The average age tends to be about 50 years old, but we have all seen patients much younger than that, some in their 20s, fortunately not very often, the 30s. I'm starting to see more and more people in their 30s, but even people as late as in their 80s are starting to come into clinics being diagnosed with this, and it happens to people from all walks of life. What's the most common clinical presentation? Well, if we're fortunate, it's what we call an incidental finding on a CT scan. Somebody's having a CT scan for something totally unrelated, and a good radiologist picks up that the appendix doesn't look normal, that it looks distended, it's filled with fluid, and they get the person to somebody who has knowledge about this, a surgeon that knows to take it out and take the next steps. But more oftenly, though, people actually present with symptoms. And symptoms, unfortunately, that are related to a more advanced stage of the disease. And these symptoms include things like just vague abdominal discomfort. How many times have I heard somebody say they really couldn't put a finger on anything, they just thought they were getting a little more sedentary, they weren't exercising, they thought they were putting on weight, their belly was getting a little distended, only to find out that it wasn't that at all. Some people are fortunate, if you will, to present with appendicitis, and they actually come in and they get a surgery and they get the diagnosis. Hernias, we see this all the time. A man goes in to get a hernia fixed and the surgeon runs into gelatinous mucinous stuff. A mass, just somebody one day feels a mass in the pelvis growing in the abdomen. Sometimes people just present not feeling well, decreased appetite, feeling a little fatigued. Hopefully, once the symptoms are brought to light, the person will go on to get some sort of an imaging study, most oftenly, a CT scan, oftentimes an ultrasound or an MRI, which we're starting to use more frequently. I know people are concerned about the effects of radiation from CT scans. This often then leads to a biopsy or a surgery of some site, whether it's to remove the appendix or perhaps the right colon where the appendix is arising from. And this provides information as regards the pathology. So again, I go back to the comment that I made. I specifically say mucinous tumors and cancers of the appendix. Just to review a little bit of cancer biology, our normal cells are born, they mature, they function, and then they die. They may divide a couple of times to make new cells for us, but overall, they have a finite lifespan. This system is highly regulated, it is very complex, and what happens when you lose that regulation is you create tumors. So tumors occur when cells become what we call immortalized, and this occurs through a loss of regulation of the cell division. No longer is the cell programmed to be born, grow, mature, and then die, maybe divide a couple times. It is now programmed to divide, and they keep dividing, and they make a tumor. But not all tumors are cancers. I'm sure probably everybody in the room knows somebody that has a little fatty tumor on the arm or somewhere, and it's gotten to a certain point and it stops growing, and that is called a lipoma. And you've heard of ladies that have fibroids and fibroadenomas of the breast. These are not cancers, but they're tumors. So not all tumors are cancer. Cancers occur when these cells that make the tumor, these immortal cells, can now migrate to other parts of the body, set up shop, and make new tumors. And so when we talk about tumors of the appendix, we're often talking about what we call mucinous cyst adenomas. And when we talk about cancers of the appendix, in this particular symposium, we're specifically talking about mucinous adenocarcinomas. And these come in a variety of different grades or degrees of aggressive biology, from a low grade or well differentiated to a moderate grade to the high grade, poorly differentiated, and the dreaded signet ring cell type of cancer. And here's just a schematic of sort of the spectrum of these mucinous tumors, arranging from normal on the right side of the screen through that cyst adenoma tumor to the true cancers, the adenocarcinomas, the low grade, a moderate grade, and the high grade. Why do we care about this? The reason why we care about this is because it has impact on what we're going to offer the person in terms of treatment and the prognosis for that person. And a lot of people are familiar, who are dealing with this problem and have gone online and done their own research, are very familiar with the Ranette criteria. And so they are often asking, where do I fall in this Ranette criteria? And this is a pathological classification of these tumors. There are 3 categories: disseminated peritoneal adenomucinosis, or DPAM, the peritoneal mucinous carcinomatosis, and an intermediate grade of peritoneal mucinous carcinomatosis. This is what the DPAM looks like under the microscope to the pathologist, and I'm not a pathologist, I'm not going to give you a lesson in histology, but what I'll suffice it to say is that this DPAM is the closest to normal of the categories that I just listed for you, but what it consists mostly of is the mucin, and maybe some abnormal epithelial cells that have come from one of those mucinous cyst adenomas. There's really no evidence of cancer in the DPAM. As you go up the scale to the PMCA, what you start to see is the cells under the microscope really look less and less normal. They're looking less as farther away from a normal cell. They start to take on features that suggest that they have this ability to spread to different parts of the body and set up shop and set up new tumors. And the slide, the figure 2B actually demonstrates the signet ring cell type of adenocarcinoma, which is so named just because the way it looks under the microscope, it resembles a signet ring. that people are familiar with based on where the mucin is in the cell compared to the nucleus in the cell. This is a picture of the PCMA-I, which is a combination of the DPAM, so a lot of that mucin, and some adenocarcinoma cells. And so this is a way for us to try to put the different types of pathology that we see under the microscope into categories so we can start deciding what treatments are best for the person and offer them some information about their prognosis, because that is really one of the main questions that people have when they come to see us about this problem. And the reason why this is important, this slide shows you that this is what we call a survival curve. On the y-axis or the vertical axis, you see the percentage of people that are surviving, 100% at the top, and on the horizontal axis or the x-axis, you see survival in terms of months. And if you have the DPAM type of histology, let me just state again that all these patients were treated in the same fashion regardless of what their histology, what their pathology showed. And the patients with the DPAM had the longest survival. The patients with the more aggressive type of cancer, the PMCA, had the least amount of survival. So that's why we care when we're really pushing our pathologists to tell us what they think is going on and they're looking at it under the microscope. So in addition to having some imaging studies, getting a biopsy, looking at the pathology, we will also be interested in something called tumor markers. And tumor markers are proteins that we can measure in the person's blood that are specific, or relatively specific enough, to the tumor cells or the abnormal cells. And this is a way for us to, if somebody hasn't had treatment yet, to check what we call the baseline level of their tumor markers, see if they are elevated. If they are elevated, treat the person and monitor those tumor markers to see if the treatment is being effective. And if we bring them back down to normal, then we can follow those tumor markers going along, and if they start to rise, it's a suggestion to us that there are cancer cells somewhere that we need to be looking for and figuring out what we're going to do next. So the treatment for this particular problem, as Dr. Whalen was saying, because of its rarity, because of the manifestations that it has, and because of the treatments that are involved, it really takes what we call a multidisciplinary approach. And that includes getting surgeons involved, getting medical oncologists involved, having pathologists who are knowledgeable, having radiologists who are knowledgeable, who can help us follow people after the treatment to see if they've had a recurrence. It may involve, the treatment itself may involve surgery, intravenous chemotherapy, intraperitoneal chemotherapy, which you're going to hear more about from Dr. Alexander. But what we end up deciding to do depends on the pathology itself. Does the person have an adenoma, or do they have an adenocarcinoma? If they have an adenocarcinoma, what is the grade of that? Is it the low grade or the high grade? And it also depends on the location. When we look at the CAT scan, where are these tumors? Are they spread all throughout the belly cavity? Are they just in one location? Are they right near the appendix? Have they spread outside the belly cavity? And that is really what we call the staging of the cancer. I'm not going to go through this in detail. We are sponsored by the Cancer Center of Excellence and the Cancer Committee, so I do want to just let people know that we do have what we call a staging system. This is put out by the American Joint Committee on Cancer, and for the first year, this is for the first time appendix cancers actually have their own classification. Up until this recent version, appendix cancers have been associated with colon cancers, which are a close cousin, but very different. And so I just would explain to people that the way we stage cancers is we look at the primary tumor, we look at features of that, the size, how far has it grown through the wall of the appendix. We then look at if there's been a surgery that has removed lymph nodes in that region. Has any of the cancer cells spread to the lymph nodes in that region, and if so, how many? Then we look at, has the cancer spread anywhere else, in the belly cavity itself or outside of the belly cavity? And then the pathologist looks at it under the microscope and tells us it's a low grade or a high grade. And we put all that information together and we come up with a staging system. So a lot of people are very familiar with the different stages. Most cancers are staged 1 through, or 0, if there's really minimal disease, through stage 4. And everybody comes to the clinic and asks me, what is my stage of my cancer? And as I mentioned before, because of the silent nature of these tumors, most of them technically present at stage 4, But I want to emphasize that not all stage 4 cancers are equal. So we hear about stage 4 cancers of other types of cancers, and you hear about dismal prognosis from that. But a person who has a stage 4 with a DPAM, who can get a complete tumor debulking and heated chemotherapy and gets right into a definitive treatment program, that person's prognosis is not the same as a stage 4 person with, a very aggressive lung cancer. And so all stage 4 cancers are not the same. So what are the treatments? If I can tell who's been, when I come into the clinic, there's usually the patient and somebody else, and sometimes there's a lot of people, which is wonderful to see the support. But I can tell if somebody's been online or not, and it's by the size of the of the eyes. And you go online and you start looking this stuff, and it gets scary really quickly, and I know that. And one of the treatments that everybody in the room is familiar with is the concept of the aggressive tumor debulking surgery and the heated chemotherapy. And this is a cartoon that actually one of Dr. Mansfield, who's my mentor down at the MD Anderson Cancer Center, put together for him. And when you start to explain this to the person, I think this is the vision that they have of what's coming next. I'd just like to spend a little bit of time on going over some of the treatment options and how we approach it. Again, as I went back, it really depends on what's the pathology, where is it located, and the person. Where are they in their stage of life? Are they physically fit to undergo the treatments that we're thinking about? So we usually start if it's a low grade or the cystadenoma, and we lump the low grades and the cystadenoma together. And this is where it gets confusing for people, because people will say to me, do I have cancer? And the answer is, if you have a mucinous cystadenoma, well, technically you do not have cancer, but this has a very malignant cancer-like behavior. And so people say, well, what should I tell my family? And it is a very difficult concept, not only for the person who's thinking about the last slide that I just showed, but for us to define amongst ourselves, the people who are really dealing with this on a daily basis. So if the person has a low-grade adenocarcinoma or a cystadenoma, it's contained, it hasn't perforated, we can, usually the recommendation up front is going to be just get the appendix out, maybe take out part of the right colon if you need it to get a clean, what we call clean margin on the end of that appendix. You don't need, we as a group have really come to recognize that these low-grade adenocarcinomas rarely spread to lymph nodes, and so we're working away from recommending more aggressive surgery to remove the whole right side of the colon. If a person's in this category and they have some peritoneal spread, if it is outside of just the area around the appendix, this is when we start thinking about should this person have the cytoreductive surgery and the heated intraperitoneal chemotherapy. And these are the patients and people who will benefit most from that approach. If a person comes and they have up front a diagnosis of a high-grade adenocarcinoma, and the subcategories of those are the adenocarcinoid, the poorly differentiated, the signet ring cell. If it's contained to the appendix, we actually do recommend removing the part of the right colon to look at the lymph nodes in that region that are associated with the appendix, just to make sure that no cancer cells have spread to those lymph nodes. If they have, then we're going to be thinking about giving intravenous chemotherapy. Because these cancers are more aggressive, they tend to grow more quickly, intravenous chemotherapy has actually been we're starting to see data showing that it's effective. And so if it has spread outside the appendix and in the peritoneal cavity, many of us that treat these cancers on a regular basis are recommending intravenous chemotherapy first, including the surgery to remove the right colon, and then to consider the cytoreductive surgery and the heated intraperitoneal chemotherapy as part of the comprehensive management of this problem. And then if you're in the middle somewhere, it's really taken on an individual basis. So again, if it's contained to the appendix, we recommend removing the right colon. These have a higher likelihood of spreading to the lymph nodes than the low grade. If there's lymph nodes that are involved, we would recommend intravenous chemotherapy. And also this group of patients would be considered candidates for the cytoreductive surgery and the heated intraperitoneal chemotherapy. So unlike other cancers where there's lots and lots of patients that we've studied over many, many years, and I'm thinking specifically of cancers like breast cancer and colon cancer, where a person walks in and boy, they fit right into this category, and here's the menu. We're going to do your surgery and your radiation, and you're going to get chemotherapy, and it's going to take this long, and then you're going to be done, and this is your prognosis. We are not in that situation. There's just not enough patients. There's not enough, fortunately, there's not enough patients, but there's just not been enough of that sort of rigorous analysis of a large experience for us to be able to answer questions in that manner for people. And that's why it's so, the challenging part of being a part of this disease. Many people will ask, well, how long is this going to take? Well, obviously it depends on what we have to do. If we're doing surgery alone, people can recover from an appendectomy or a right colon removal in a couple of weeks and get on their way, and then they'll get into a surveillance program. If it's surgery and the heated intraperitoneal chemotherapy, it can take 4 to 6 months for people to really get back on their feet, feeling like the wind is back in their sails. In that time period, we hope they're getting back to work if that's what they're doing, or getting on with their life, and then they're on to the surveillance program. For the more higher grade types of cancers, where we're talking about intravenous chemotherapy and then possibly the surgery and the heated intraperitoneal chemotherapy, it's a long, involved process. We may be looking at 3 to 4 months of intravenous chemotherapy followed by surgery, recovering from that, additional chemotherapy on the other end. So it really can vary in how long the definitive treatment may be, and then the surveillance continues on. Many people ask, how soon should I start my treatment? Many people want to start yesterday when they show up in my clinic. But even with the high-grade tumors, fortunately, the incidence of this tumor spreading outside the peritoneal cavity is very low, and fortunately, most of these tend to be very slow-growing. So there's time to consider options, and there's time to get opinions, and I encourage that in everybody that I see. And many people that I see have come to me, and they've already met 3 or 4 other specialists in this area, and it's wonderful. There's a good side and a bad side to that, because you could get 3 or 4 different opinions, all of them making sense at the time that you're hearing them, and then I know that it's difficult to figure out, well, which one am I going to follow, and how do I decide who to see? The other downside of that is, over time, if the situation progresses, it can be harder to achieve the best possible outcome, so people are also racing against that time factor as well. People often ask, what is my prognosis? And again, I go, this is actually a question that oncologists and surgical oncologists, we struggle with, because we have information in our heads about the average. What does the data tell us? But we all know the person that has beaten those odds and the person who hasn't even come close to those odds. And so when we're looking at the person as an individual in the clinic, and we're thinking, trying to put all this information together in our heads, what did the pathology show, and what does the CAT scan show, and what have they had for treatment already, and how old is this person, that sort of thing. It's really hard to come up with a number. And we can pull a number out of the air, and just the chances of us being right are so small that we really try to sidestep that question somewhat. But again, it's multifactorial. It depends on pathology. It depends on the location or locations of the tumor, and it depends on the intervention or interventions that a person has had. Many people ask, how will I be followed? Well, clinic visits, regular clinic visits, imaging studies with either CT scans and or MRIs are becoming more useful in this disease, and the blood tests that I mentioned before. And those clinic visits are usually more frequent shortly after the diagnosis and the definitive treatment, and then as a person does well and has no sign that the cancer is coming back, those clinic visits and those visits and follow-ups will get less and less frequent. What happens if it comes back is another question that I got. Well, again, those decisions need to be made on an individual basis, and it depends on the pathology. Oftentimes I get asked, I have the low grade now, but if it comes back, could it be the high grade? Fortunately, that's not the most common thing that we see, but anybody who's taken care of a lot of people with this problem have seen that happen. So that's another a piece of the puzzle that we need at the time if it comes back. It also depends on the location or locations. If it's in one spot in the belly cavity, we may think about just doing another surgery. Keep an eye on it for a while and see what happens, and then maybe do another surgery. If it comes back in other parts of the body, then we do another treatment like intravenous chemotherapy. And it also depends on what's been done before. I know I have people that I've cared for who have had the heated intraperitoneal chemotherapy more than once. So there are all kinds of options that we have to offer people. A lot of people ask, what can I do to prevent it from coming back? And boy, I wish I had something, because I'd have everybody on it. I'd have it in the drinking water if I could. But there's nothing that I know of, and I don't know, Dr. Sullivan's going to be talking about the rest of this list, and if she has any suggestions about preventing it from coming back, I'll defer to her. But we always recommend the usual things: eat healthy, maintain a healthy weight, exercise, quit smoking, and don't start if you haven't, and all things in moderation. What causes this? I've heard people ask me, they say, I've worked with depleted uranium, I was a hairdresser for my whole life, I got struck by lightning. I wish I knew. Because if we knew who was at risk for this, we have a simple operation to prevent it from happening. We could just take out people's appendixes. There are many theories. I think the H. pylori, or the bacteria theory, is fascinating, and look forward to hearing the results of future studies, and there are ongoing investigations. Many people, I know Dr. Goodman has a program looking at the genetics of the tumors themselves. And how long have I had this? Unfortunately, probably for years. All these tumors in cancer start with a single cell somewhere that divides, and 2 cells become 4 cells, and so on and so forth. And these do tend to be slow growing. So it's probably been years. We'll never know exactly, but it's probably been there for a long time. And the other question I get all the time is my family at increased risk? And I always say, unfortunately, no. And that sounds a little bit weird. But I get back to that. If your family was at risk and we knew that that was a strong predictor of who was going to get it, we could do prophylactic appendectomies and prevent this from happening in a large number of people. So your family is at the same risk that you were of getting this very rare disease. And then for young people, I often hear, we want to have children, and will this be possible? And so I know Dr. Alexander is going to talk a little bit more about the surgery of this, and I know that he and I share a similar philosophy that we try to remove the least amount of things from a person and just get the tumor out when we're doing the debulking surgery. And in ladies particularly, try to keep the uterus and ovaries if they're of an age where they might be thinking about having children. We usually recommend that people wait about 2 years after the definitive treatment, because the chance of it recurring in is greatest in the first 2 years. The people that this topic does require early and upfront discussion about other options for future pregnancies. And there's actually been a recent report in the literature of at least 6 women who have safely had children after the heated intraperitoneal chemotherapy. So that's very encouraging news. So just want to summarize or just sort of emphasize what I think is the importance of a peritoneal surface malignancy center, such as the one at UMass, such as Dr. Alexander's program, Dr. Goodman's program, because this is such a complex and rare condition that we are only beginning to understand. And I think in order for people to do as well as they possibly can, and for us to advance the field in understanding and improve the treatments that we have, you really need a dedicated program with a multidisciplinary team that includes surgical oncology, medical oncology, palliative care, pathologists who understand the tumors, radiologists who know how to read these, what can be very subtle findings on a CT scan or MRI, nurses who understand what the patients are going through before and after the surgery, case managers and social workers who are in tune to all the issues around recovering from the surgery and the surveillance. As Jim said, you're not alone. Again, I can't thank the PMP Research Foundation enough for sponsoring this symposium. Check out their website, it's wonderful. We're hoping that this will be broadcast, it's being videotaped, and it'll be broadcast on the website for them. Many people in the room are familiar with the PMP Pals support group, Gabriella Graham, who's been an incredible advocate for people dealing with PMP and appendiceal cancer, and a couple of other websites that I know people are checking out regularly. So we've got a lot of heavy lifting to do in the future, but I think if we all pull together, we'll get there eventually. But thank you very much for your attention. Thank you for coming.